Okay, Tal.
All right. Okay. Hi, good evening, everyone. Thank you for joining our monthly webinar. As usual, we have a very special guest with us today to give us a very interesting talk. So today we have Mr. Christopher Lee. He is the consultant urologist. I am so sorry. I'm getting a last. You need to take over.
Okay. All right. Mr. Chris is a consultant urologist in HPUPM. So today, he's very kind to share with us his knowledge regarding obstructive uropathy, which is actually a common encounter for us working in the emergency department. And I think because we do not have any urologists in-house, so I hope that by having this lecture, it will give us some guide on when should we consult the surgical, or when we can basically consider to give them the patients as an outpatient appointment, and they are safe to be discharged. So without further ado, I would like to invite Mr. Chris to proceed with his talk today. The floor is all yours, Mr. Chris.
Okay, thank you very much, Masarina. Thanks for having me this afternoon. It's indeed a pleasure to receive an invitation to speak to all of you. I must say this is actually the first presentation I've made to an emergency department. Most of the time present to fellow urologists and trainees. So it's indeed a pleasure and the first experience for me. So the talk today is about obstructive uropathy management and what an ED personnel needs to know. It's slightly different from what I would usually present to a urology crowd, a bit more tailored to emergency department. So I'll start the lecture with an overview. Of course, we can't introduce a topic without a definition. So that's what I will start with, followed by the epidemiology, etiology, pathophysiology, patient typical presentation, and the basic workup that's necessary in ED, and also simple treatment that we can offer. Okay, so obstructive uropathy it refers to a functional or structural obstruction to either one or both kidneys, which leads to renal injury. Okay, the key word here is renal injury. If there's only obstruction, then it's only it's a urinary obstruction. There is no uropathy without the component of the renal injury. Okay, so this obstruction may occur at any level of the urinary tract. It could be upper tract, which refers to the kidneys and the ureters, or it could be the lower urinary tract, which refers to the bladder and the urethra. Okay. The common pathway, common outflow of urine flow is from the bladder neck and the urethra onwards. So if there's an obstruction at that level, then the entire system is obstructed. Okay, so symptoms are based on the site of the obstruction, the degree of obstruction, and also the duration of the obstruction. You can divide epidemiology into a gender predominance based on age groups. And in the pediatric age group, it's generally due to congenital anomalies. And for example, vesico-ureteric reflux and also posterior urethral valves. In this age group, males are more affected than females because of the existence of posterior urethral valves, which is exclusively in males. For the below 20 years age group, the incidence is equal between males and females, whereas between ages of 20 to 60 years, it's more common among females due to pregnancy and gynecological conditions. After the age of 60, however, it's more common in males due to prostatic disease. Okay, so we can divide the etiology into mechanical and functional causes, right? There are three anatomical sites which have natural narrowings in the ureter, namely the pelvic-ureteric junction, where the ureter crosses the pelvic rim, and lastly at the vesico-ureteric junction. These are natural narrowings, but they can be further narrowed in the presence of any inflammation or infections. The next structural cause is congenital anomalies. So these will be detected either antenatally or at birth, or even in the early childhood years. And examples of these are erythroceles, ectopic ureters, megaureters, and posterior urethral valve. The next cause is inflammation, for example, infectious cause or post-surgery, causing inflammation to the tract. Intraluminal causes include stones, which are one of the most common causes of obstructive uropathy. Blood clots, although they are soft, they can also cause obstruction, similar as papillary slough. Okay. Neoplasms could be intrinsic, for example, urothelial carcinoma, and they could also be extrinsic, meaning that a malignancy of a nearby structure, for example, bowel or the gynecological organs, are causing compression to the urinary tract. The last cause is trauma. Here you will have a typical history of trauma, and it causes obstruction by disruption or compression of the ureter or urethra by a hematoma. Indeed, the ureter and urethra can be completely disrupted, meaning there is no continuity. This would lead to complete urinary obstruction. For functional causes, they are either neurological or musculogenic conditions, which affect the ureter or the detrusor contractility, and they can also affect the urinary sphincter relaxation. Examples of neurogenic conditions are stroke, Parkinson's disease, very severe diabetes mellitus, spinal cord injury, and also multiple sclerosis. Some medications such as anticholinergics and antihistamines also can cause functional obstruction. And examples of musculogenic causes are myasthenia gravis, or chronic obstruction leading to thinning of the detrusor muscle, which eventually leads to trabeculations and diverticulae. Next, we move on to the pathophysiology of obstructive uropathy. So I've divided this into the few sections. In the urethra, the changes that occur are proximal dilatation due to the obstruction itself. In the bladder, in the early phase, there's hypertrophy, there's compensatory hypertrophy of the detrusor to try and overcome the obstruction, which is seen as trabeculations on cystoscopy. There can also be saccules and diverticulae due to the increased pressure within the bladder. And later, the bladder dilatation occurs and the walls become thinner as the detrusor muscle undergoes atony. And as a result of this, you can have urinary retention. In this case, it would be chronic urinary retention. In the ureter, similar changes occur. In the early phase, you have muscular hypertrophy, and in the later stage, you get muscular atony, where the ureter becomes dilated, elongated, and tortuous. Okay, as a result of the increased pelvic calyceal system pressure, there are some changes that occur to the kidney. The renal pelvic musculature hypertrophy occurs initially, and then eventually, same as the bladder and the ureter, the muscle stretches out and becomes atonic. Then the calyces become flat, then they become clubbed, and then finally they become ballooned. And this are the various stages of hydronephrosis appearance. The renal parenchyma eventually thins out because it undergoes ischemic atrophy due to the pressure within, which is where the parenchyma is compressed between the renal capsule and the intrapelvic pressure. So in the end, the cortex becomes paper thin and non-functional. Okay, the functional changes that occur within the renal parenchyma are the intrapelvic pressure rises above the glomerular filtration pressure. Okay, intrapelvic pressure is the pressure inside the pelvic calyceal system. When that pressure rises above the GFR pressure, the urine secretion will stop. And the GFR and renal blood flow will also become reduced. And at this stage, the renal concentrating power is lost. If there's only unilateral obstruction, the contralateral normal kidney will undergo hypertrophy to compensate. And damage is still reversible if this is treated early. So early treatment leads to recovery of the morphology and function of the kidney. And there are several factors that will affect the changes and the degree of damage that occurs. First is unilateral versus bilateral obstruction. In unilateral obstruction, there's compensatory changes that occur in the contralateral kidney, whereas if there's bilateral obstruction, then there is no compensation by either side. Complete versus partial obstruction. Obviously, if there is a complete obstruction, the damage will be much worse compared to a partial obstruction. And as for the duration, a chronic obstruction will cause more morphological changes, which is hydronephrosis and elongated ureter. But an acute obstruction will cause a more rapid function deterioration, especially if the obstruction is complete. And superimposed infection will also have an adverse effect on the compensatory mechanism and the function of the kidneys. Right. So you might wonder, how does the kidney recover and whether there is any recovery after relief of obstruction? There is, if treated early, as I mentioned earlier on. But we don't have human studies on this. It's only based on animal studies. So basically, we can assume that there is some degree of recovery after relief of obstruction. If it's relieved within 14 days, then a full recovery can be expected. If obstruction occurs for 1 month, then only about 31% of recovery can be expected. And after 2 months, it's a very grim prognosis with only 8% chance of recovery. Okay, the next part is the presentation, the clinical presentation of the patient. Okay, this of course depends on the level of obstruction. If the obstruction occurs in the upper urinary tract, the patient will probably complain of colicky pain if the obstruction is of an acute onset, right? So the patients that you get in emergency who present with obstructive uropathy generally have 3 main symptoms, which are pain or fever, or they come with some acute kidney injury. Okay, so yeah, colicky pain is a good guide. They might complain of the typical renal colic, loin to groin pain, which may radiate down to the scrotum in males and the labia in females. Hydronephrosis will become apparent after about 72 hours, and you may pick this up on a bedside ultrasound scan. If the patient has infection, the patient will complain of fever, being generally unwell, lethargic, maybe some malaise, and some loss of appetite as well. This could also reflect a renal function impairment where the patient presents with the acute kidney injury. If the obstruction is in the lower urinary tract, it depends on whether there's acute cause or chronic cause of obstruction. In an acute cause, the patient complains of obstructive lower urinary tract symptoms, which are hesitancy, poor stream, intermittency, terminal dribbling, and incomplete voiding. May not be all of these symptoms, but some of them. In the worst case scenario, the patient will come in acute urinary retention. If the cause of the obstruction is chronic cause, for example, an enlarged prostate or maybe a bladder tumor, the patient will also have the same obstructive lower urinary tract symptoms. And on top of that, the patient may have overflow incontinence, which is a leaking of urine from a very full bladder. Yeah, and the patient will also probably come with renal impairment to a certain degree. And the complications of this are bladder trabeculation, which is the hypertrophy of the detrusor muscle, and eventually this leads to diverticulate and a vesico-urethric reflux as well. And it's this reflux that causes the renal impairment because the pressure is transmitted to the kidneys. Okay, so what do you need to do if you have a patient you suspect has obstructive uropathy based on the symptoms and signs? So a few basic tests which is available almost everywhere in every emergency department. Of course, you need to start off with a renal profile, okay, to confirm your suspicions. Look at the urea, the creatinine, and also the urea-creat ratio. Calculate the eGFR and look for electrolyte imbalances, especially hyperkalemia. PG is also useful to look for any acidosis in the case of AKI. And if you suspect the patient has any element of infection, FBC would be helpful as well. In patients with underlying CKD, you would also probably find a patient is anemic due to the reduced level of erythropoietin secreted by the kidney. If you suspect that the patient may have urinary stones, do send calcium, serum calcium and serum uric acid as well. And tumor markers may be helpful sometimes in looking for any possible tumors causing an external compression to the urinary tract. I've included PSA, although prostate cancer is not a very common cause of urinary outflow obstruction, as some people might think. Yeah. Urine tests, a simple urine FEME or urinalysis, has a few useful components, namely nitrite, which is quite specific for urinary tract infection. RBCs are quite general. They could be positive in stones, infections, tumors, even presence of foreign objects such as stents and urinary catheter. You will have RBCs as well. Similarly, for leukocytes, which present in infections, inflammations, you can also find them in stones and also foreign bodies like catheters. Yeah. Okay, so we move on from the laboratory test to imaging. The most simple imaging is a KUB X-ray. It's fast, cheap, low radiation, but unfortunately, it's only useful in the case of urolithiasis. The next one is also X-ray, but it's a serial X-ray we call IVU or IVP, which is intravenous urogram or intravenous pyelogram. We don't do this commonly anymore because we have CT scans nowadays in most major hospitals. But in the rural hospital setting, this could be very useful if you have a patient that comes to you quite unwell, yeah, and you don't have any CT scan. IV contrast is needed, so you have to be aware of acute kidney injury or patients with CKD, and you need to ask the patient about contrast allergy as well, yeah, because sometimes you forget to ask them. This is done by serial imaging. First of all, a pre-contrast X-ray is taken, which is essentially a KUB X-ray. And after the infusion of IV contrast, you can take a nephrogram at 1 to 2 minutes, and in the nephrogram, the renal parenchyma will be enhanced, and you can see the renal outline on the X-ray. After about 10 to 20 minutes, you take an excretory phase. You may take a few serial images during this period, okay, to see the gradual enhancement of the pelvic calyceal system, followed by the upper ureter, lower ureter, and then the bladder as the contrast slowly gets excreted into the system. So in IVU, you can identify only the outline of the collecting system and the ureters and bladder, and you can see filling defects such as stones, tumor, blood clots, but you cannot see any surrounding organs. Yeah. Okay, the next test is ultrasound. This is a cheap, radiation-free, non-invasive, and widely available tool. And I believe that almost all emergency departments will have an ultrasound machine. So it's very useful if you are able to do a simple bedside ultrasound yourself and not wait for the radiologist, because sometimes there are some simple signs that can be detected at our level in emergency. And also for myself as a urologist, sometimes it takes a bit too long to wait for the radiologist. So we do our own scans. So this is where ultrasound becomes very useful, because it's available almost everywhere in the emergency department, the clinics, and even in OT as well. Yeah. So ultrasound is able to detect masses and stones in the kidney, the pelvic ureteric junction, the vesico-ureteric junction, in the bladder, and it's also able to detect hydronephrosis, look for the bladder thickness, and also measure the prostate size. However, ultrasound cannot visualize the entire length of the ureter because the ureter is a retroperitoneal organ and it's covered by bowel, which has gas. So it does not conduct the sound waves very well. Ultrasound serves to guide, it can either make a diagnosis or it guides further imaging if there's any abnormality found. For example, if you see a stone, you would order a CTU. If you see a mass, you order some other scan. Yeah. The downside of the ultrasound is, of course, it's operator dependent with roughly 25% false positive findings. Okay, CTU is the non-contrasted CT scan, which is best modality for urinary stones. Okay, in urinary stone disease, this is the final scan that you need to plan any surgery or any intervention, any treatment. Yeah? It's able to detect the exact site of the stone, measure the exact size, the exact shape of the stones in case of Staghorn calculus. You can see the number of stones and also some complications from the stones such as hydronephrosis, and even in pyelonephritis, you would have some streakiness around the kidney. So you can see a lot of things based on this CTU. Okay, certainly it's enough to plan for surgical management of the stone. So it's compulsory it's a compulsory imaging for any stone in the urinary tract. Even if you detect a bladder stone, you would still get a CTU because you don't want to miss stones in the upper urinary tract. Okay, the next CT scan is what we call a 4-phase renal CT. So this is obviously a contrasted scan, and the 4 phases are the plane, which is before you give contrast, the corticomedullary, where you see the renal cortex enhanced, the nephrographic phase, where the whole kidney is quite uniformly enhanced, and finally the excretory phase, where the contrast goes into the collecting system and the ureters and the bladder. This is the best modality for renal parenchymal tumors or cysts, any urothelial tumors, or renal inflammatory or infective conditions. It can also assess causes of extrinsic compression because it not only looks at the genitourinary tract, it can see the entire content of the abdomen as well, abdomen and the pelvis. Caution is required in patients with renal impairment, of course, because the intravenous contrast is required. CT-IVU is the CT version of IVU or IVP, but it's of course superior because you can see the surrounding organs as well, and not only the internal outline of the urinary tract. Now, radionuclide scans are not widely available. Okay, only in certain tertiary centers it's available, and this is not one of the routine scans you would order, especially not from the emergency department. Yeah? But it's useful to assess the differential function of the 2 kidneys. Okay? Examples are DTPA, DMSA, and MAC3 scans. These radionuclide scans are able to assess the concentrating ability, the excretion, and the outflow obstruction of individual kidneys. Okay, it's good to compare the left and right kidney to assess which is the better kidney, to assess the preoperative baseline function of both kidneys, or even to prove that one of the kidneys is non-functioning, where a less than 20% differential function indicates a non-functioning kidney. Okay, it's also able to give a qualitative assessment of the outflow obstruction. Yeah, it can tell you exactly which level the obstruction occurs. Right, MRI is of course a very expensive scan. It's no radiation, but it also requires contrast. Yeah, it's not commonly utilized in obstructive uropathy because we can get all the information we need from CT scans and other forms of imaging. Most of the time it's indicated only in pregnant women that cannot have any radiation. But even in MRI, we're unable to visualize stones where they only appear as filling defect, as you can see in the picture on the right. Yeah, the whitish part, the round whitish part is actually a renal cyst. This is the pelvic-calyceal system, and the dark hypointense lesion there, which is round, that is the filling defect, which indicates a stone. Okay. So the other use of MRI is able to delineate tissue planes in case of any tumors, especially in the pelvis. Yeah. Okay, so that's for imaging. We move on to a more invasive investigation. This is very familiar to us. Cystoscopy is very rarely done in the emergency department. I'm not sure whether there's any emergency department that can cater to this investigation. Most of the time it's done in the operating theater, daycare center, or even a urology clinic. Yeah? So this is an invasive test, as I mentioned. It's very uncomfortable, depending on which scope you use. We have a flexible cystoscope and we have a rigid cystoscope. The one in the picture on the left is a rigid cystoscope, which is a very painful procedure, especially in males, due to the length of the urethra. So some form of anesthesia is required, depending on what scope you use, ranging from local anesthetic to regional anesthetic. Okay, this cystoscopy allows direct internal visualization of the urethra, prostate, bladder, and the contents within. For example, if there are any tumors, stones, or blood clots. Yeah? It also allows performing a retrograde pyelogram and any simple therapeutic procedures. It also allows you to take any biopsies if there are lesions, suspicious lesions, or remove small stones and clots. Okay, we move back to imaging for a minute. This is a retrograde pyelography, which can only be done via a cystoscope. That's why I put retrograde pyelogram here after cystoscopy. It allows us to conduct a real-time assessment, okay, where you can take a continuous fluoroscopy image of the contrast as you inject it into the ureter from below, yeah, from the ureteric orifice. You can inject the contrast. You can see the contrast going up into the renal pelvis. Okay, but similar to the IVU, it's only able to visualize the luminal characteristics and the filling defects. It does not give you any other anatomical details. Okay. However, if you are doing a RPG, it also allows you to do simple intervention. For example, a stent, urethral stent insertion, urethral dilatation, or even take some urine samples for cytology. And this is safe in patients with renal impairment because the contrast is not injected intravenously. Okay, so those are the investigations that are required to diagnose and to assess the severity of the obstructive uropathy. Next, we move on to the treatment. Now, the treatment has several objectives. One, of course, is to relieve the obstruction as soon as possible, to correct the derangements that have occurred due to the obstruction, to treat any superimposed infection, and identify and treat the primary cause or disease if possible. Okay. Now, all treatments start with medical therapy before surgical therapy, but a lot of conditions may not be amenable to medical therapy. There are specific criteria where you can try medical therapy first, and they are if there's only a unilateral or partial obstruction, if there's a small intraluminal obstruction that has a chance to pass spontaneously, and in the absence of infection and renal impairment. Now, all of these criteria must exist at the same time so that to allow you to try medical therapy. Okay, if you do not meet this criteria, then it is dangerous to attempt medical therapy. You should consider surgical therapy. So the medication that we're talking about are alpha blockers. For example, tamsulosin, alfuzosin, doxazosin, and terazosin. And this is indicated in distal ureter stones, which are more than 5 millimeters and certainly less than 1 centimeter. Why more than 5? Because if the stone is less than 5 millimeters, then it has an equal chance of passing even without the medication. Okay. You may also consider giving prophylactic antibiotics. The common ones we use are Bactrim, cephalosporins, fluoroquinolones like Ciprovay, and Augmentin and Unicin. Okay, these are all useful for urinary tract infections. Okay, now we move on to surgical therapy. So the goal of surgical therapy is immediate relief of the obstruction. Okay? This serves to restore the normal flow of urine and decompress the obstructed system, and also serves to promote recovery of the renal function. There are certain conditions where immediate relief of obstruction is necessary, and these are if there is a complete urinary obstruction, if there's obstruction in the solitary functioning kidney, if there's obstruction complicated by infection, if the patient has some renal failure, and if the patient has uncontrolled pain due to the obstruction. So I've divided the surgical therapy into a lower tract and upper tract. The treatment for lower urinary tract obstruction is somewhat simpler and more straightforward. Okay. The options of treating this are a urethral catheter versus a suprapubic catheter. I'm sure most of you are very well versed with an insertion of a urethral catheter. And this is what we always attempt first, except only in the case of suspected urethral injury, where the patient would have an obvious history of trauma. And on examination, you see blood at the urethral meatus, perineal hematoma, a high-riding prostate on a digital rectal examination, or a distended and palpable bladder. So in the absence of all this, you can try inserting a urethral catheter. Okay. Suprapubic catheter is only used after a failed attempt at urethral catheter, or if you suspect urethral injury and you'd like to avoid inserting a urethral catheter. However, inserting an SPC is only possible if you have a clinically distended bladder, which means it's palpable. So for a suprapubic catheter, it can be done under a local anesthetic. You must be able to palpate the bladder in order for you to insert the SPC. Otherwise, you'll be puncturing bowel instead of bladder. There's a landmark for the insertion of the SPC, which is in the midline of the abdomen, 2 finger breadths above the pubic symphysis. So obviously, the bladder must be palpable at a level much higher than that for you to be able to safely puncture the bladder. Okay. So the picture on the left shows the landmark, anatomical landmark, where it's safe to puncture the bladder. And the picture on the right shows you a typical suprapubic catheterization set, which consists of essentially a blade, a trocar, which has a sheath, and the catheter itself. So after puncturing the bladder with the trocar, the trocar, you remove it, and that leaves a sheath for you to insert the urinary catheter. And then after the urine drains out from the catheter, you can remove the sheath. Yeah? Some of the sheaths are peeled. You have to pull it out of the patient's body, then peel it and break it in half so that you can remove it from the catheter. Okay, so for upper urinary tract obstruction is not as straightforward. Most of the time, I would say it cannot be done in emergency department. I'm not sure whether any centers overseas would have an OT. Actually, in fact, I know of a few tertiary hospitals which have OT attached to their emergency department, where you can just push the patient right across and perform some simple surgical procedures. I'm not sure if Putrajaya has a OT in the emergency department. Do you?
No, we don't.
Okay. I think HKL does. That's probably the only hospital I've worked at where it has attached OT to the ED. So for upper urinary tract obstruction, the options are placing a urethral stent, as you can see in this picture, versus a nephrostomy tube. Okay? The stents are usually inserted retrogradely via a cystoscope, as I mentioned earlier. And nephrostomy tubes, however, are inserted antegradely via a percutaneous puncture. Stents can also be inserted antegradely if retrograde method fails. What the radiologist would do is put a wire through the nephrostomy, guide it down to the bladder, and then they would push the stent over the wire and leave it in place. Yeah. In the case of urosepsis with obstruction, a nephrostomy tube is generally preferred, as usually it can be performed earlier because placing a stent requires bringing the patient to theatre, and that is subject to the emergency cases that are going on in theatre. So if the nephrostomy can be performed earlier, that would be the preference. Yeah. Okay, the last thing that I'll touch on is a condition called post-obstructive diuresis. Okay, this is a polyuric response to the release of urinary obstruction in the case of bilateral urinary obstruction, or obstruction in solitary kidney, or in the case of a bladder outlet obstruction. Okay. This is diagnosed when you have a urine output of more than 200 mils per hour for 2 consecutive hours. Okay. The causes can be physiological and pathological. In the physiological phase, the diuresis occurs to eliminate excess sodium, urea, and water that has been accumulated during the time of obstruction. Whereas for the pathological phase, there is an impaired concentrating ability or sodium absorption due to increase in the atrial natriuretic peptide in the glomerulus, or the reduced response of the collecting ducts to antidiuretic hormone. Okay, so either way, you get very much increased urine output regardless of the amount of fluid intake. The result of this is a very large negative balance, okay, which you need to treat. So the way to treat this is by strict intake output monitoring, okay, regular renal profile monitoring. You can do it once a day, every day, and you need to manage the fluid replacement as well. Okay, you can do that by combined oral plus intravenous fluids, where you give normal saline. The replacement is not one-to-one. It's one-to-one on the first day. Usually, you can give 100% replacement, which means if the patient produces 2 liters of urine per shift, then you replace with 2 liters of normal saline in the following shift. Okay, for example, for the first morning shift is from 7 to 2 p.m. So over the next shift from 2 to 9 p.m., you'd be replacing the exact volume of urine that the patient has produced. Okay, so you do this for day 1, and on day 2, you reduce that to 75% of replacement, 75% volume replacement. Okay. On day 3, you can reduce that to 50% and then reduce it 25% on the 4th day, so on and so forth. Okay. So the aim is to allow time for the patient to recover while replacing the excess fluid lost in the urine. Okay. You should also avoid overhydrating patient, because if you overhydrate, for example, if you give 100% replacement every day, you would prolong the process of the obstructive post-obstructive diuresis actually. Okay, that's my last slide. Thank you very much for your attention. I'm happy to take any questions if you have.
Thank you, Mr. Chris. I'm so sorry for the earlier glitch. I had a hospital call that I had to take, so sorry about that.
No problem. Yeah.
Thank you very much. That was a very, very informative lecture. We will wait for some questions. While we're waiting, I have some questions actually.
Sure.
I would like to ask your advice on most of the time in emergency, we have patients who comes in with renal colic. You know, they come in renal colic, urine FME, RBC is 5+, but otherwise RP is normal. Pain is well managed with pain management and hydration. So these patients are dischargeable.
Mhm.
What would your advice be for us to discharge? Usually when we discharge, we will say either TCA stat when the pain reoccurs, or we will give a TCA to our surgical clinic. Is there any investigations that we need to do prior sending this patient to the clinic, X-ray or CTU? What would your advice be?
Yeah, so as one of my slides spoke about the degree of damage that's done to the kidney if you prolong the duration of the obstruction. So in order to sort of make things move faster for the patient, every patient that you suspect has renal colic should have a confirmed diagnosis upon discharge, which means that you would actually have to do a CT scan, CTU, all right? You can start with the KUB X-ray. KUB X-ray, 90% of urinary stones are visible, are radio opaque. So if you see that, then you can proceed straight to do a CT urogram, which is the non-contrast CT scan. And this is very, very easy because you don't need to fast the patient. You can do it any time of the day. And you can do it in the patient regardless of the condition. Okay, you don't need to hydrate the patient or anything. Just send straight for a CT scan. It's a plain scan. So upon getting the diagnosis, not only would you be able to prove that the patient has a urinary stone, you can also assess for hydronephrosis. Now, if the patient has hydronephrosis, then the obstruction is not, it's acute, but it's serious because it could mean a complete obstruction. Therefore, there is some urgency to managing this patient. This patient should not be given a review after 2 weeks or a month. You should pick up the phone and refer the patient directly to a urology center. Then they will decide how early they can see the patient. Yeah, of course, you need to send a renal profile as well, and any derangement in the renal function, of course, is a very bad sign, and therefore increases the urgency for you to refer to urology.
Doctor mentioned about KUB X-ray, right?
Mm-hmm.
So is it still good to be done in unfasted patients who are not fasted?
KUB X-ray, yeah, fine. You can do it in anyone.
Fine.
Yeah.
Okay. Another thing is RP doesn't need to be deranged. It can be normal in
Yes,
patients
correct.
with obstruction.
Yes, you're very right. Yes.
Mm.
In the case of a unilateral kidney obstruction, the renal profile can still be normal, right? But what we notice is, you think about it logically, humans can survive with one kidney, okay? But in patients with young, very fit patients, very healthy patients with a unilateral obstruction, they do get some degree of AKI as well. Now, why that happens is while the normal body is used to 2 functioning kidneys, a suddenly non-functioning unilateral kidney will cause the total renal function to reduce. And it takes a bit of time for the contralateral side to compensate. So if you catch it within that window, then you would see some AKI as well. But you're right, regardless of whether there's AKI or not, once you make a diagnosis of obstructive stone, in this case, then you should make an immediate referral to urology.
Okay.
Some people would think, okay, there is a stone, there's hydronephrosis, but the renal profile is normal, the creatinine is not elevated. Okay, we can wait. There's no urgency. We'll refer to surgical clinic in a month's time. And then when the surgeon sees, they say, oh, we need to refer to urologist. They refer after a month. So there goes 2 months, and there's permanent damage to the kidney. So that's not actually the right process of treating these sort of patients.
Yeah, I think our surgical colleagues here needs to hear this as well, because most of the time when we see stone and we call them, they will say that, oh, the renal profile is normal. We can see them later in clinic. So yeah.
Yeah.
And I was asking, that one is if KUB X-ray we see stone. What if we say the KUB X-ray is normal? How do we proceed after that?
That's a very good question. So when you have a normal KUB X-ray, at this point in managing this patient, you have no clear evidence that you're dealing with a urinary stone or obstruction due to any other cause. So because of this, ultrasound becomes very useful, and ultrasound would be able to give you more clues. As I mentioned in my talk, you cannot visualize the entire length of the ureter on ultrasound because of the bowel gas. So you would look for other clues such as hydronephrosis or stones elsewhere in the system, like in the kidney. Kidney stones may not necessarily cause obstruction, but then again, if you have a kidney stone, you could very well have a ureteric stone, which is most of the time is a stone that has dropped from the kidney. Okay, so these are very good clues to show that the patient does have an obstructive stone. And with these signs, it gives you more confidence in making a diagnosis and therefore ordering a CTU.
But we have to bear in mind these patients, in normal, I think in any KKM hospitals, we have difficulties getting ultrasounds and CTU itself. Will it be okay if like we do not see anything in X-ray, but I can discharge the patient, I get an ultrasound appointment for this patient as soon as possible, and I give a TCA to surgical clinic?
Yeah, I mean, I think this is what happens in almost all public institutions, public hospitals. This is done not because it's the best way to manage, but this is done because of the sheer volume of patients that we see in the emergency. Unfortunately, I have to say there is probably no choice. We have to do this. Otherwise, even as urologists will be receiving many referrals every day, and some of them turn up actually there's no obstruction. So is it okay? Actually, no, it's not. But I do understand that we have a lot of limitations in the system. So I would suggest that if you do make a clinical diagnosis of a renal colic and you are unable to get the radiologist to do the scan immediately, maybe you can do your own bedside scan. I believe you have an ultrasound in the emergency. So just do a very quick bedside scan. It's not easy. I must admit, it's not easy, especially if you're doing it for the first time. But if there is moderate to gross hydronephrosis, you would be able to see it. Picking up a stone is not as easy, but hydronephrosis is quite easy to see. So if you're really concerned, just do a bedside scan. And if there is hydronephrosis, then you would have good reason to request an urgent CT scan for this patient. So use this as a weapon against your radiologist.
Usually, but I think now all of my fellow EPs would agree that we do ultrasound for all renal colics because we want to find this hydronephrosis and everything. It's just that the early stage of this obstruction that's a bit difficult for us to detect in ultrasound, like you said. So this kind of the patient, like you said, a lot of limitations. So we try our best.
And also that brings me to a question. If you do get these sort of cases, do you typically refer to your surgical colleagues, or do you refer directly to urologists?
We do not have urologists here, so we need to go through our surgical colleagues.
Okay. Would you considering referring directly to a urologist? I mean, as a urology center, or is that not the...
Yes, we would love to. If there is someone who's willing to accept our call, we are more than happy to give that call.
The problem is, I think the proper workflow is for the surgical team to refer, right? I understand. And the stumbling block is when the surgical colleague does not want to come down to see the patient.
Yes, as long as the RP is normal, no one comes down.
Even if the RP range, they will discharge the patient.
Well, this lecture is recorded, right? So maybe you can share it with them. I mean, we're aiming to save nephrons. So every I wouldn't say every minute counts, but I think every day or every week counts when you're dealing with obstruction.
Thank you, Mr. Chris. Another thing is regarding prophylaxis antibiotics. In what cases for us in emergency department that we should and we must start prophylaxis antibiotic?
Well, I would say if you have a patient who is prone to infection, elderly or the very young, or patients with any reason to have immunodeficiency, like diabetes, which is extremely common, then I would consider starting prophylactic antibiotics. But otherwise, it's not commonly indicated.
All right. Nas, anything would you like to ask?
Yeah. Mr. Chris, I would like to ask regarding post obstructive diuresis,
Yeah.
which I see commonly associated with patient that comes in, elderly patient that comes in with AUR. And the main cause is normally because they have this BPH. So ideally, how long do we monitor this patient at emergency department? Because the flow that I normally observe is they will observe for maybe about 2-3 hours once the renal profile comes back, and this patient will be referred as outpatient to the surgical clinic. If they are unfortunate, they will go only to clinic kesihatan to win off their CBDs. But there was no proper there is no proper evaluation being done for this patient. So how would you recommend in terms of the flow of management of patient for this kind of category, so that we do not discharge them prematurely and we will be able to solve their problem at the same time later on the course of AUR?
Right. So ideally, once you make a diagnosis of post-obstructive diuresis, which is more than 200 mils of urine per hour or 2 hours. So if they have, then the patient needs to be admitted. As patient cannot be properly managed in the emergency department, okay? Because managing post-obstructive diuresis requires a few days, not a few hours. Okay, so if they do not have post-obstructive diuresis and there is no renal impairment, which requires hydration, then yeah, you can discharge the patient and aim to remove the catheter at the usual time after 2 weeks or so. Yeah. So if there is post-obstructive diuresis, if this diagnosis is made, then the patient must be admitted for monitoring and fluid replacement. It cannot be managed in ED unless you're willing to keep the patient for about 2-3 days. I've seen patients with post-obstructive diuresis extending beyond 1 week as well. So it's quite variable. Some patients recover faster, some take a long time to recover.
Okay. I have one more question. If patient comes in with partial AUR, can still pass urine, but the urine, like for example, they have incomplete voiding and so forth, is it recommended for us to insert a CBD? Because in my center previously, the neurologists are not very happy when we insert the CBD for this type of patients. So what is your comment on that?
Well, I'm not sure which context you mean when you say the neurologist is not happy, but generally, if there is obstruction, we need to relieve the obstruction. So I would recommend inserting a urinary catheter. If you're talking about acute urinary obstruction, it's more necessary because acute causes of obstruction do not resolve spontaneously. Okay, whether it's a enlarged prostate or stricture or stone, it does not resolve spontaneously. So acute retention requires inserting a catheter. Chronic obstruction is different. Chronic obstruction is where the patient has a very large distendable bladder, and despite still being able to pass urine in a small amount, the patient can never empty the bladder, right? So in a chronic obstruction, it's highly recommended to insert a catheter because there are complications to chronic obstruction, which are a bladder stone, UTI. Okay, they are at very much increased risk of UTI due to the urinary stasis. So in this case, in chronic obstruction, a drainage is still highly recommended. Okay, I don't think there's any condition where there is urinary retention which is contraindicated for CBD. It's still recommended, whether it's acute or chronic, still recommended to have a CBD.
Right, thank you. I just wondering, with one last question.
Sure.
Does HP-UPM accepts patient if, let's say, the patient is able to pay? Because I know the payment is a bit different from
Yes. Yeah, of course. So we, if the patient has a guarantee letter from any government or government-linked institution, then they don't have to pay. But if without the GL, then the patient has to pay. So yes, we do accept all referrals.
All right, sure. Thank you very much.
You're most welcome.
Any more questions from the audience? I think that's about it then. All right. Thank you very much, Mr. Chris. Thank you for sharing your knowledge with us. It's a pleasure having you with us today.
You're most welcome. It was a pleasure for me as well.
Yes.
As I mentioned, the first experience presenting to the emergency physicians. Thanks for the opportunity, and have a nice evening.
All right. Thank you. Thank you for all those has been joining us. See you all next time then. Thank you. Bye.
Bye.
Mr. Chris.